Hi, thank you for joining us for the Hunter New England Public Health Update. My name is Phoebe James and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on today and pay respect to elders past, present and emerging. Just wanted to mention before we start that this session is being recorded. The recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. We're having a Q&A session at the end of the presentation, so feel free to put your questions in the box and we'll endeavour to get to them. There are also 2 handouts attached to this session. You can access and use them. These resources are directly from our Health Pathways website on the adult pathway under antiviral, which I encourage you to visit. There will be an evaluation at the end of the session. It's very important that this is completed. Tonight, we have Ellen Sempt, who is our new Manager, Disaster and Emergency Management, who has recently joined the Primary Health Network. We also have Michelle Redford, who's a GP at Black Buck Doctors, Peter Walk, who is a Senior Staff Specialist in Respiratory and Sleep Medicine at John Hunter Hospital, and a Conjoint Professor with the University of Newcastle. And lastly, we have Sandra Fitzgerald, who is a Health Pathways Clinical Editor. I will now hand over to Ellen.
Thank you, Phoebe. Hello together. It's a pleasure to meet you. My name's Ellen Senft. I'm the new Manager of Disaster and Emergency Coordination at the PHN and based in the Newcastle office. The last years have proven that natural hazards and infectious diseases are a major and likely threat that may profoundly affect the GP community and their ability to deliver primary health care. Disasters also threaten business continuity and challenge the mental health of health providers and their patients with long-term effects. This is why the PHN wants to assist the GP community with a strategic approach to develop, expand and consolidate their preparedness and disaster resilience towards all sorts of hazards that may occur in the future. My role will have a focus on developing such a structural multi-hazards approach that addresses the needs of our GP community and which may assist you in your decision-making process when preparing for a disaster. This tool we are developing will also give you information about resources that can be accessed to alleviate the pressure and the damage disasters may have placed upon your practice and the workforce. The organizer also asked me to provide a few words on my professional background. I have 8 years of experience delivering primary health care as a dentist in Germany. I then decided to pursue a career in public health and graduated from the UNSW Master of Infectious Diseases Intelligence program, which also included an education in managing health aspects of crises, emergencies, and disasters. I subsequently gained 14 months of invaluable experience working as the pandemic coordinator for a local German public health department during 3 major COVID outbreak waves from 2021 to 2022. In this position, I was responsible for the administration and surveillance of 34,000 COVID cases, as well as outbreak investigations, response and mitigation planning, which included responding to outbreaks in the primary healthcare and residential aged care setting, and for assisting providers in disaster management and preparedness development. During this time, I acted as a communication focal point for all stakeholders that were involved in the pandemic response. This included primary care providers, residential aged care providers, school and hospital representatives, the local and federal health department, disease surveillance bodies, and the German Armed Forces IT battalion. For over 1 year, the German military had to deploy personnel to assist in contact tracing and database administrative tasks, and at times they also deployed surge capacity personnel to heavily affected residential aged care facilities. Regarding GP services, I was involved in commissioning healthcare services such as testing clinics to facilitate upscaling measures and relieve GP practices. After 2 local GPs sadly passed away after contracting COVID, the service continuity in the district was in danger as the GP density in the district was low from the start. I was involved in managing the systematic transfer of patients from the 2 deceased colleagues to other GP colleagues who still had capacity or who could create surge capacity, but this was a very difficult task. It was a lot of pressure on a system that has already been understaffed and fatigued by a 2-year intensive pandemic response. But I must say that I was at all times impressed by the high level of motivation and dedication the GP community of that German district displayed and how well the cooperation was performed. It was the power of the communication between a network of individual GPs that facilitated resilience and recovery during the most horrific times with excessive workloads and high business risk. My impression is that the Hunter New England GP community is equally connected. This connection will help us through the upcoming times in which we unfortunately will have to deal with the threat and effects of hazards and disasters on a regular basis. After February 2022, I was also involved in planning the primary healthcare response to an emerging civil disaster. After the Russian Federation invaded the Ukrainian country, which borders the east of Europe, my catchment area in Germany experienced an increased influx of refugees, and there was the need for coordinating and commissioning of urgent private care services and for testing for COVID and tuberculosis. The refugee influx is still ongoing, which shows us that one disaster may be superimposed by another, and all of a sudden our priorities change and actions have to be adapted. Well, I'm very pleased to be working with the PHN, and I'm looking forward to a fruitful collaboration with the GPs of the Hunter New England and Central Coast region. Thank you for your attention, and I will now pass on to Peter Ward. Thank you.
Okay, thank you very much, Ellen. Can you see my screen?
No.
No. It worked so well earlier, didn't it? Hang on.
Doesn't it?
Here we go.
There it is.
Okay, fantastic. All right. Sorry about that. Thanks, everybody, and thank you, Ellen, for the introduction. Hopefully, being in Newcastle won't be as busy for you as what it sounded like you were in Germany. That's most impressive. Look, thanks once again to everybody inviting me to come and talk tonight. I'm going to touch upon all things a bit COVID here at the moment, but concentrate a little bit on the long COVID space as well. We've already had an acknowledgement, and I'd also just like to pay my respects to elders past and present, the Worimi and Awabakal people upon which we're meeting tonight. So I think we're all pretty grateful that we've emerged out of the most recent winter that we've just experienced, and certainly for us in Hunter New England Health, and particularly in respiratory, it's been a particularly busy winter. This is the curve that we've witnessed with COVID-19 in 2020. Well, this goes back from 2020 through all the way to 2022, and you can see the level of activity that we've experienced, particularly from January onwards. We've obviously had a very rapid influx of COVID from what we experienced with the August outbreak, which began in Sydney and which was predominantly Delta. And then, of course, the very major January, February outbreak that we had, which was all Omicron BA1, as you could see there. But things just got better and better, as you all well know, with BA2 leading to a significant spike in March and April. The lull between April and May there was taken up by the surge that we saw with influenza illnesses, which were the highest we'd seen in the last 6 years. And then, of course, building on that, we then went straight into BA4 and BA5. And thankfully, we're now seeing that that's gradually starting to abate. But throughout that period of time, as you can see, it's led to an enormous amount of activity that we've experienced in Hunter New England Health, and I'm sure that you have experienced as well. On the left-hand side here, we have the daily 7-day rolling average of people admitted to hospital with COVID within 14 days of their diagnosis. And you can see that that count was really quite high in January, settled a little bit, but peaked again in winter. And on the right-hand side is the number of people in hospital with COVID at any one time. Again, you could see we got up to 3,000 cases mid-January. We didn't quite get there with the BA4, BA5 outbreak in winter, but for a far more sustained period of time of 6 weeks, we had greater than 2,000 people in hospital at any one time. This was a substantial workload, needless to say, and unfortunately it's going to have had a lot of flow-on effects, of course, for other business of usual activities and some of the usual surgeries that we would have been hoping to try and catch up on by now. However, it brings us hopefully, at least for now, to the end of the current wave, and that's clearly got some implications if we're talking about the long COVID space. Before I go there though, I just wanted to very quickly touch upon Evishield, or tixagevimab silagevimab, which is a monoclonal antibody which is licensed under the TGA and soon to be approved by the Pbs for the prevention of COVID-19. Now, you know that monoclonal antibodies have come and gone to some extent, and as the virus has changed and the variants and different variants have emerged, this has also been a problem for Evishield as well. And it lost considerable activity against BA1, but retains quite reasonable activity against BA2, BA4, BA5. And in New South Wales, well over 97% of our isolates are BA4, BA5. So this is an agent which is given as an intramuscular injection. It is designed to be given to people who are at high risk of acute COVID-19 and in whom vaccination is unlikely to be effective. So these are really the most immunosuppressed of our immunosuppressed individuals, either those people with hematological or solid organ transplants, oncology patients undergoing active treatment, particularly immunosuppressive treatment, and of course solid organ transplant patients as well on very high level immunosuppression, or anybody on a B-cell depleting immunosuppressive, such as omestinumab or rituximab. So it has been demonstrated to be highly effective. This was a randomized controlled trial that was published at the beginning of this year in the New England Journal of Medicine, where a single intramuscular injection, well, actually it's 2 intramuscular injections with this agent, leads to effective antibody levels against the virus that binds to the spike protein and prevents the virus from entering into human cells. Now, the way that that Evishield has been designed means that this has a very prolonged half-life, and it offers a successful level of monoclonal antibodies for at least 6 months and probably up to 9 months. In patients whom received treatment, you can see that treatment led to a very substantial reduction in hospitalization, a relative risk reduction of around about 83%, with 95% confidence intervals between 66 and 92%. And if you look to the time to admission, you see the same thing, a marked reduction in the hazard ratio for patients admitted to hospital treated with Evishield compared to those who received placebo. So this is an effective preventive agent to stop highly immunosuppressed individuals from getting COVID-19. I must say I wish we had been a lot more systematic in rolling this out earlier, because I think it would have had a much more dramatic effect on reducing some of the difficulties we saw in June and July. but nonetheless, it is becoming more widely available, and it will probably be available on the PBS within the next month or so. So you do need to be aware of it, and there is a health pathway that outlines that in a lot more detail that Sandra will talk to you more about. But on to post-acute problems with COVID-19. Again, I'll point you in the direction of health pathways. We are developing some strategies, and we have now developed a clinical practice guideline for the assessment and management of adults with post-acute sequelae of COVID-19, and that of course now is starting to include long COVID. And so again, health pathways is aligned with this document, and it's designed to try and give you a framework to consider the issues in regarding long COVID. This is not a well-defined condition, as you'll see. Symptoms that persist for more than 3 months following diagnosis, and consistent with the definitions that both WHO and NICE have, which are really not particularly well-defined, and really quite a number of different persisting symptoms in this space. So a condition that occurs in individuals with a history of probable or confirmed, in the Australian experience that should be confirmed, of course, usually 3 months from the onset of COVID-19, and with symptoms that last at least 2 months and cannot be explained by an alternate diagnosis. Now, as you can appreciate, that's not very well defined. There's going to be a lot of overlap, particularly when we look at features such as comorbidities that both increase the risk of people developing long COVID, but also are complicating some of the pictures that we see with long COVID. So this is very much an area under development. The emergence of new literature in regard to this is slowly but surely coming through. Much of the existing literature is pre-Omicron. We do know that the higher rates of post-acute COVID complications that were seen before Omicron do not seem to be occurring at the same prevalence with the Omicron variants. And probably our best estimate is that around about 4% of patients with acute COVID will go on and satisfy those criteria for long COVID at 3 months. We do know that there are certain factors that will increase the risk of long COVID: hospitalization and more severe acute disease, older age, pre-existing frailty. Comorbidities feature very highly, of course, both chronic lung disease and diabetes. And in this case, unfortunately, both asthma and COPD seem to be risk factors. For the younger cohort of patients, obesity is a very strong risk factor. And while vaccination status almost certainly reduces the risk of long COVID, it does not completely protect you against it. And there may still be a rate of around about 20% excess risk of long COVID, even in face of vaccination. More inflammatory markers acutely and consistently female sex. So the mechanisms remain poorly understood, and for the reasons of time, I won't go into any of those. They really exist in the space of hypothesis generation at the moment, and we really do need to do a lot more work in this space. And these are the 10 most frequently reported symptoms that I'm sure you're all starting to experience and see now: fatigue, breathlessness, persistent cough, though fortunately that does seem to reduce after the 6-month mark, worsening depression, anxiety, formal diagnoses of PTSD, neurocognitive impairment, joint and muscle pain, mobility impairment, palpitations and chest pain, anosmia, and difficulties with taste. This is probably the largest of the databases that have reported now, the PHOSP data, and it's looked at follow-up points at both 5 months and 12 months. This is a UK-based study, and looking at those 5 and 12 months presence of symptoms. So this is a group of individuals who were referred to a long COVID clinic at 5 months, and how many had persistent symptoms at 12 months. Unfortunately, those who had ongoing symptoms at 5 months were also very likely to still have symptoms at 12 months, though there was clearly some improvements there. So it's this cohort which is looking like it may be quite persistent. Again, most of these cases, though, were alpha and delta. But what is becoming clear is that this is really quite a multi-dimensional problem, and these people are not likely to have just one single problem. They are likely to have multiple issues, so multiple symptoms such as breathlessness, post-exertional fatigue, malaise, difficulties with mobility, and cardiovascular symptoms as well. Again, when you look at the factors associated with worse recovery, pre-existing comorbid illnesses features very highly, unfortunately and consistently female sex again, and more acute disease appears to be a fairly important risk factor. The UK have certainly approached the model with this tiered approach integrated very clearly with primary care. I'm not sure that we've quite systematically got our act together yet, but both the Commonwealth and state governments are putting together a national long COVID strategy that will broadly follow in the same sort of line, acknowledging that there will be a lot of people. If we have well over 8 million people who have had acute COVID, 4% of them having long COVID, we're probably talking about 500,000 people that will have some symptoms at least. That is obviously a large number. Most of them will hopefully be able to manage either themselves. A proportion will obviously need to be managed in primary care, and hopefully only a very small proportion will need more specialist services. Self-management is going to become a really important part of this, and there are resources underway and being developed at the moment to try and support this, but I think that this is going to be very crucial, and these are some reasonable examples that are available, the UK resources probably being the most comprehensive and helpful in this space. So where do we go now? Well, we do need to consider the size and the scope of the problem. We do need to structure and standardize. We have to look at different models of care that are themed to clinical problems and not confined to single diagnoses. We need an approach which is going to be holistic, and I know I'm obviously talking to the converted there. We need an evidence-based approach, but of course I've got to be frank and say that that evidence base just does not exist for many of these problems yet. And it is likely we're going to need a hierarchical approach, one that concentrates on self-management aspects and then scales up from primary care to secondary care to supportive services around that. And I think we need to be flexible and understand and learn from this experience. In New South Wales Health, we're trying to convince them of a treatable traits approach to this problem. So you'll have to pardon my use of a respiratory example here. But this treatable traits concept that we talk about is identifying the components of a disease that are present, identifying which of those can be measured, and then identifying how you're going to treat each of these individual approaches in those individuals. So we can't group all these people together. To put up a shingle and say we're going to have a long COVID clinic is really unhelpful if you have a whole batch of different problems there that will need specific solutions. So if I extend this and say, well, how might this look if we were looking after people, say, who present with ongoing breathlessness? And we know that's probably about a third of all those individuals out there with long COVID. Breathlessness features highly. It's early on the most likely reason that someone will present again to the emergency department or even require readmission to hospital. But ongoing symptoms of breathlessness, as I mentioned, probably in about a third of all individuals. So this is something that limits people's activity, is likely to have an impact on their quality of life, and it may not be just experienced in those who had severe disease. However, in terms of breathlessness and the risk of someone developing persistent lung disease, there is a strong relationship between the severity of the acute illness and the severity of the respiratory impairment that occurs at certainly 3 months and 6 months. When we look at that cohort of individuals who seek help because they're breathless, we see that it's common, as I said, about a third of all patients, and around 10 to 15% may have symptoms such as cough. But how we go about assessing them and looking to see who has underlying lung disease is going to be really quite important. Relying on things such as spirometry alone, unfortunately, is not going to be that helpful. Spirometry that is restrictive is present in only about 10%, and that's not going to be enough. That's only obviously a small proportion. However, if you send them along to a lung function laboratory and they have significant breathlessness, then if you detect an abnormality on gas transfer factor, they are more likely to have underlying persistent interstitial lung disease. And that's about the same as what you would see if you did CT scans on everybody. The costs of those two tests is vastly different, with a CT scan being around about $450 to $500 to Medicare and a gas transfer test being $128. So spirometry DLCO for people with significant breathlessness and an abnormal chest x-ray should identify those who do have underlying lung disease. And there's lots of different changes on CT scans, but they're not particularly predictive in that post-acute phase of ongoing problems. They will eventually resolve, and if you do CTs early on, as we've done here in this 46-year-old woman who had severe acute COVID, she certainly had persistent ground glass changes even at day 32. It gradually resolved, and by 12 months had nearly completely resolved. So one CT often doesn't, of course, allow you to escape without doing another, and any persistent abnormality often leads to a second scan. So persistent breathlessness, when should you investigate? Well, this UK cohort of over 3,000 patients, they did this approach with spirometry, DLCO, and a chest x-ray, and they found that around about 6.9% of these people were at high risk of having persistent and significant interstitial lung disease. Scans were very good at picking this up, but using a screening approach of breathlessness, a DLCO of less than 80% predicted, and an abnormal chest x-ray allowed you to choose the individuals that would benefit most from having a CT scan. So we're going to propose that if you see a patient, if they've got significant breathlessness, which is persistent, then that first approach with chest x-ray, spirometry DLCO, and then go on to further investigations if needed. Certainly in the immediate post-acute space, some concern does exist about the possibility of pulmonary emboli. Now, the risk of this dramatically reduces after about the 6 to 8 week mark from hospitalization. A very, very small number of individuals may have chronic pulmonary thromboembolic disease, but it is a very small number of individuals. Again, this is a paper that was published at the end of last year. Over 2,000 people followed up following hospitalization for acute COVID-19 and reviewed in the 90 days following discharge. Most of them had persistent breathlessness. Only 1.3% though had evidence of pulmonary emboli or DVT. And that risk was more likely in those who were sicker, who had a lot of inflammatory markers during their acute admission, and of course if they had a very high D dimer, but I appreciate that most people aren't going to know that. So what do you do? Well, if you are seeing somebody within that 3 months and they're still breathless and you think they might have a pulmonary embolus, I'd recommend treating them like you would anybody who you think might have a pulmonary embolus. So assess them clinically, do a serum D dimer on those individuals. 6 to 8 weeks following their acute illness, it shouldn't still be positive. If they're a low probability, low D dimer, there should be no reason to go on and do further investigations. High probability or a D dimer of greater than 0.5, look for a PE, do a CTPA or a VQ scan. So this is obviously going to be quite an evolving area at the moment. Sandra will bring up the end and outline that the clinical practice guideline is now being reflected in health pathways, and there should be plenty of information and resources. You have to appreciate that this is an evolving field and that we will be adding to this as we gain more and more information and progressing onwards. So wait to hear more about this space, but thank you very much for listening tonight.
Thank you, Peter. I'm just going to get you to turn your camera on, please, because we do have a few questions that have come through before you run away.
Absolutely. I'll try.
Thank you.
Well, I'm clicking it. Is it on? No.
No. That's okay.
Ask away,
So I have
and
two
I'll keep trying
questions
to
from
work out.
Raj.
Yes.
Okay,
Yep, go ahead.
perfect. Two questions from Raj. The first one being, is long COVID as prevalent in the third world?
Oh, that's a great question and one without an answer. There is such a dearth of data outside the developed world for both COVID and long COVID, Raj, that I honestly could not answer that question. I have not seen anything particularly good that looks at any of those prevalence, despite some of those countries having really quite large acute problems as well. It certainly exists there, not that China is part of the developing world, but there is certainly good evidence about proportions of long COVID in China that reflect what we've seen in Western nations and in Europe and the United States, but no hard prevalence data. And I've not seen anything in countries like India, which obviously had major outbreaks of COVID and continue to have problems. It's an excellent question, but I'm afraid one I'd have to take on notice.
Okay, thank you. And the second question again from Raj, how useful is lung ultrasounds for long COVID respiratory diagnosis?
It probably has no role to play outside of a research one, in a nutshell. There's some very interesting stuff that people are doing with acute COVID-19 and pneumonitis and ultrasound, but ultrasound's not a particularly helpful test for detecting underlying interstitial lung disease anyway. For that, lung function tests and CT.
Okay, thank you. We will move on to Michelle. If you have any last minute questions for Peter, please put them in and we'll try to squeeze them in before he runs away.
I finally got my camera to work.
Yay!
So I'm pressing the button to share my screen, but I don't think anything is happening. Oh, good. Here we go. Bear with me whilst the IT warms up.
We can see your screen.
Wonderful. Okay. So my name is Dr. Michelle Redford. I'm a GP at Black Buck Doctors in New Hampton, and I'm a GP advisor to the Hunter New England Central Coast PHN in the integrated care team. And I would also like to acknowledge that we're on Awabakal land and pay my respects to leaders past, present and emerging. So thank you, Ellen and Peter, for your wonderful presentations. I'm just going to be whizzing through a few bits and pieces of what's changed around vaccination and a little bit about some of the practicalities of antivirals. A little bit of a review of the current epidemiology, just because we didn't manage to get a public health person to come and speak today, but Peter has given you a bit of an overview of that. Hot off the press, the bivalent Moderna vaccine booster that was just approved by TARGI yesterday, and some other bits and pieces. So I'm just going to start with the epi. So that's a familiar slide probably. It's fairly similar to the one that Peter showed. So the bottom in the green there, that's ICU, and the top is overall admissions. This is for the whole of New South Wales, and it goes back to the beginning of January. So hopefully it's going to continue to go on the downward slope. So that's COVID. And this is overall data, and this shows in the red the proportion that are diagnosed on rat. versus the proportion diagnosed on PCR. So this is all probably very familiar, but again, reassuring to feel that maybe we are on the dip down until we get another wave of something else anyway. And flu, hopefully we're past the worst of the flu peak, and seems to have already peaked. And this is the all sorts of various respiratory viruses, so adeno, RSV, enteroviruses, rhinoviruses, and we're currently in the green, on the green line for 2022. And again, most of these are trending downwards, thank goodness, after a few months of an awful lot of respiratory illness seen both in general practice and of course in the emergency department and the hospital. So how do we prevent some more COVID? This is the latest version of the COVID-19 vaccines chart. It's getting a bit crowded now, but somehow they're still managing to get it to fit on one page. So we do have the new Spikevax vaccine for under 5s. That's now appeared on this chart. So if you don't have a copy, that's the address where you can find it, and it's actually quite a useful summary. AstraZeneca probably eventually going to disappear off the end, but not much clinical use of AstraZeneca anymore. But just to highlight that resource is available. It's also linked through Health Pathways. And this is currently out of date, but it's the latest one that's on the Department of Health website of trying to summarize some of what has been quite confusing about the dose intervals. So I'm going to just mention a couple of things about dose intervals later on. So yeah, this is the bit that's hot off the press. So it was approved by the TGA a little while ago, but Atagi have just come out on Monday and approved the Moderna bivalent vaccine just as a booster. So there's no first primary courses with this, and it's going to be rolled out from sort of beginning of October to replace the current Moderna booster vaccine. And essentially the processes are otherwise all the same, but it targets two strains, so the Omicron BA1 and the original 2020 strain. And while it gives maybe a bit of an advantage over the other vaccine against both those strains, there isn't any advice to wait until it's available. So if you're due a booster, whether it's your first booster or your winter booster, you are encouraged to just get on and get it and not to delay for the bivalent vaccine. So that's just about that. Also from Moderna, we've now got the pediatric vaccine, which is for 6 months to less than 5 years. And this is for a very select group of severely immunocompromised children or children living with disability or complex and multiple health conditions increasing the risk of severe COVID-19. So these are going to be children we would expect that are going to be under specialist care, and they are not it's not a vaccine that is going to have a very broad application, but just so that you know, those are the conditions for which it's indicated, and it's 2-dose primary course again, unless you're severely immunocompromised, which a significant number within this group will be, and they still require a 3-dose primary course. So first dose, 8 weeks, second dose, 8 weeks, third dose, which is now become more standardized across all the primary courses now. So that's that one. Novavax has a new indication, so it can now be given as a primary course for teenagers, so age 12 plus. So it was previously restricted to adults 18 plus, and now it can be given as a primary course. There probably are not too many people out there who haven't had a primary course who want one, but Novavax is now an option in that group, and it gets away a bit from that issue around pericarditis and myocarditis with the mRNA vaccines. So that's 2 doses, 8 weeks apart, 3 doses if you've got severe immunocompromise, just like with everything else. And although it's not registered for use as a booster in adolescents, Atagi have advised that it can be used as a booster if no other COVID-19 vaccine brand is suitable. So Novavax is definitely not preferred as a booster at all in any age group, but Atagi have come out and clarified their position on that. So just a little summary of people who have got severe immunocompromise, because they're coming up a lot in various guidelines. They're the people that we're probably most worried about in terms of at risk of severe COVID. So for all people with severe immunocompromise now, who are 6 months plus, there is a vaccine available. It's different at different ages, but there is a vaccine available, and primary course is going to be 3 doses with 8 weeks between doses. Then for boosters, if you're 12 to 15, you can get a Pfizer dose after 3 months after your primary course, and then that's you done, no more boosters beyond that. If you're 16 to 17, you can have an initial booster and then a winter booster. And if you're 18 plus, you can have either Pfizer or Moderna for both the booster and winter booster. So people age 16 plus are up to 5 doses now if they're severely immunocompromised, and it's really only for that group. Also importantly for this group, if you are seeing them for vaccination, talking about vaccination, remember that they are definitely going to be eligible for oral antivirals if they test positive for COVID-19, and have a system in place to try and make sure that they can contact you if they do test positive. And as Peter has sort of said before, they also may be eligible for Evershed, which is this 2-dose intramuscular injection, 1 into each glute, that's given as just a one-off, as a preemptive strike, really. So just to be aware of that as well. Also highlighting that the PHN still is providing some additional support to help target immunisation to particular vulnerable groups. So, for example, there's a whole page on the PHN website about First Nations, and there's a form that can be filled in to get specific support for First Nations people to try and support them to access vaccination, whether it's helping them to book, helping them to get there, whatever it is. Non-Medicare card holders, they can be vaccinated in primary care, and the PHN will reimburse the cost. You just would have to contact that email address. And people who are housebound, sometimes the PHN can help out with things like taxi vouchers to get them to a service. And just that Medicare item number is still available if you're going to be visiting somebody who's housebound in the home or in an RACF or other facility, then that flagfall fee is available in addition to the usual COVID-19 vaccine assessment fee. So just to highlight that. And this is the winter booster. So this was updated a little while ago, the eligibility for COVID-19 winter boosters. You probably remember initially it was age 50 plus, but it has been widened. Oh, sorry, originally it was age 65 plus, but it has been widened now to age 50 plus. And these other groups, and we maybe are not getting as much coverage in some of these groups as we would like. If you're a resident of an aged care facility or a disability care facility, or you have a disability that increases the risk of severe illness, and there's actually probably quite a lot of people who should be getting a winter booster, and the numbers are not really quite where we would like to see them. Then in that 30 to 49 age group, it's kind of on request, encouraged, but the benefit is less certain in that age group. So that's immunizations. On to a bit about COVID antivirals, which probably we're all very familiar with now, but these are the current Pbs eligibility criteria. So 70 plus, you don't need a symptom. If you've got a positive test, you're eligible. You could be completely asymptomatic. And but it does need to be within 5 days of either starting symptoms or the positive test, whichever is earliest. And then age 50 plus, within 5 days, need to have symptoms and 2 additional risk factors. And I've just got a slide in a sec with the additional risk factors. And then 30 plus, if you're First Nations and you have 2 additional risk factors, then you should be checked for your eligibility and have a discussion as well. And if you're 18 plus, with moderate to severe immunocompromise, which is what we sort of talked about before. These are the risk factors. Now I've summarized these because on the Pbs criteria, it feels quite confusing because there's one section about immunocompromise, which then also includes a number of other things, and then another section on risk factors. So I found it a bit confusing, but this is the summary slide of things that count as a risk factor for antivirals. And so, you know, any of your people who are age 50 plus with type 2 diabetes and a BMI of 30 plus, which is, you know, probably a significant number of people living with diabetes, they're eligible before you've even really started to think too hard. So I just would encourage you to be familiar with this sort of this list, and to try and identify your patients in advance so that you can have that chat with them, so they know that they need to get tested early, and seek a PCR if their RAT is negative, and have a way of contacting the surgery and getting on antivirals. So this is just a bit about, because I think antivirals it's been so complicated, and these are just my sort of quick notes of what the main considerations are. And so most of this is about contraindications. So I think we all know that there is no antiviral during pregnancy. For breastfeeding, they haven't said that you mustn't have Lagevrio, but you have to avoid breastfeeding during treatment, and then for 4 days afterwards you definitely can't have Paxlovid. And then these little things which are really important about not conceiving during treatment and for 7 days after on Paxlovid, and also bearing in mind that it's an enzyme inducer, it interferes with the combined oral contraceptive pill. But also with Lagevrio, that bit about male patients should not conceive for 3 months after. So they should use contraception for during treatment and for a whole 3 months after. Females for the 4 days after. So that's important. And then Paxlovid, I think we probably are a bit more across some of the contraindications. You know, that if you've got significant renal failure or liver failure, then that's not going to be appropriate. And checking the interactions on the Liverpool drug interaction checker, which I think is awesome. There's also an RACGP guide, which if you haven't seen it, it takes you through the process quite nicely. And of course, it's also on health pathways, which is here. And I've just highlighted these couple of things. So these are attachments that are attached in the attachments on the webinar. So these are just a couple of little resources. One is an autofill that you can copy and paste into your software. You might need to adapt it slightly, but just saves you having to do the work yourself. You can there's one being provided, and that's quite nice. It takes you through all the steps. And also just thinking about those really high risk patients who you've identified would be eligible for antivirals, using this COVID antiviral pre-assessment and plan template. And it's just really saying, you know, this is why you're at higher risk, and this is what we suggest you do if you have symptoms, and this is the medication we think you should have. So that's quite helpful. This is the Liverpool interaction checker. So if you haven't seen it, surely we have all seen it by now, but it's a thing of beauty. And here I am checking out that my patient on lercanidipine can't have Paxlovid and has to have molnupiravir. And right down the bottom of the screen, there is a little button where you can download the PDF, and you can just save it in your patient's notes and have it there as a record. So I've been doing this a bit in advance with my patients when I have the opportunity, so that I can say, well, look, you're not going to be having Paxlovid, or you can have Paxlovid. Sometimes it says things like, oh, like with warfarin, I think it says, oh, you can have it, but you have to do some more monitoring of the INR, which just poses its own difficulties in the context of someone with COVID. So, but at least it gives you the information on which to make your clinical decision. This is the rather busy task force slide, which I don't expect you to read, but this is the whole decision guide, prescribing considerations for Paxlovid, which makes you realize why I can't put it on one slide, because it is very complicated. And this is the process that you're going through when somebody has contacted the surgery saying, I've got COVID. So that's why I'm encouraging people to do as much of that thinking in advance in a maybe slightly less time pressured scenario, because it is quite complicated. Even when you zoom in and you start looking at it, just the top half of it, it's still fairly complicated, but it is still quite a nice prompt, because it's got the major drugs there in the middle that are definitely not recommended. So yes, just for those higher risk patients, if you consider a COVID-19 action plan, if they have symptoms and they have a negative RAT, make sure they know to get a PCR and have a mechanism to contact the practice. And yeah, I would encourage you to pre-check interactions. So that's all from me. I'll be here at the end to take any questions about that little whistle-stop tour, and I'll hand over to Sandra from Health Pathways with her presentation. Thanks, Sandra.
Thank you so much. I'm having a little bit of trouble with my internet, so many apologies if I drop out. But Phoebe, can you just confirm that you can see the Health Pathways login slide there?
Yes, I can.
Fantastic. So for those of you who don't know Health Pathways, and hopefully all of you do by now, on the left-hand side is the login details for the clinical pathways for health professionals. And on the right-hand side is our sister site, the patient info, which is not password protected, and you can freely give that URL out to people to find information for patients that's been vetted by our clinical editing team. So I'm just going to quickly show you a few of the health pathways that have been showcased tonight. And the first one from Peter Walk, and apologies, my slow internet, but the first one I was going to show you was the post-COVID conditions pathway. And when it finally loads, you'll see that one of the key links that we have on this pathway is the ACI guidelines that he was mentioning and he talked you through. So over here under key links, the ACI Clinical Practice Guide for Assessment and Management of Adults, and that NHS rehabilitation booklet that he mentioned tonight, I've just requested to put down the bottom under for patients, so that should pop up sometime tomorrow. We've also been talking about care of COVID positive adults, and Michelle has already shown you a little bit about this pathway. The meat of it is here under initial consultation, and you go to the medication section, antivirals, corticosteroids, and monoclonal antibodies. The antiviral section is where you'll find all those things that Michelle has pointed out tonight. So those pre-assessment and plan templates and the autofill shortcuts. We've got the assessing the eligibility here, and we've tried to make it pretty simple for things like the Pbs eligibility. So for example, if you go to Paxlovid, you know, they've got a positive result, at least one sign or symptom of COVID, not requiring hospitalization, treatment initiated within 5 days, and then fit one of the population criteria here. And so say if they're aged over 50, they have at least 2 of the following there, and that's a similar list to what Michelle showed you. So that's the eligibility. And then the next step is to decide which agent, and all those resources Michelle showed you about Paxlovid are here under point 3, choose the appropriate agent considering efficacy, precautions and contraindications. And you'll find the Liverpool, University of Liverpool drug interaction checker here, and down the bottom they've got that fantastic Paxlovid prescribing guide. So have a play. We are always happy at Health Pathways to come and show you around the site. So if you'd like one of us to come out and just kind of help you navigate the site or learn how to use it well, or find out about the features, we are more than happy to come and do that. The other section is the monoclonal antibodies. So Peter was talking about Evusheld, and all of that information is here. And obviously, if it does go on the PBS later in the month, we will update that with the PBS criteria. But we've got the current indications, contraindications, drug interactions, adverse effects, and how to arrange supply. So all of that will be there. With respect to the vaccination, sorry, I've had to pre-open all of these because my internet is so slow. At the top of the COVID vaccination information page, you'll find those fantastic infographics and posters that Michelle was showcasing tonight. And in this note is where you'll find all the new and updated information. So we've got the key links to things like the recommendations for booster doses, medical exemptions, and then vaccination of people with immunocompromise. So have a look there for that. Just a quick note that the vaccination procedure pathway has had a change of name. It's now just called Covert Vaccination, and it's been really streamlined to help you find information about different COVID vaccines and what to do post-vaccination and so forth. And then the only other thing I would like to just share with you is the easiest way to navigate onto these pages. So if you go onto the Health Pathways homepage, right here under Health Alerts, if you're looking for the COVID vaccination information, you can just click straight on that. If you're looking for the COVID positive patient sections, there's the adults and the pediatric pathways. And over here on the left in the table of contents, under clinical care, is where you'll find the things like the post-COVID conditions. So I encourage you, if you've got any feedback at all or any questions, click on this send feedback icon. The first time you do it, it takes a couple of minutes, but once you're set up, you can send lots of feedback. So if you think there's something missing or something we need to add or something's wrong or you'd like a whole brand new pathway, let us know. We are all ears and we check that feedback every working day. Thanks so much, Phoebe.
No, thank you. Michelle, we can't hear you. You're on mute.
Of course, sorry. I don't think we have a whole ton of time for questions, so I think we've actually managed to keep to time, so that's good. But we have got a question about, isn't Paxlovid minimum age 12 and molnupiravir 18 plus, and that's absolutely correct. I should have clarified I was talking about adults. I personally have zero experience of prescribing antivirals in children. I would probably be involving the specialist team if I had a child that was that high risk, I think. But yes, you're right, and we haven't covered children tonight, but that is all on the health pathway, and there is an ACI pathway for drug treatment in children as well. So.
And we certainly do have the Paxlovid information. Sorry, I should have mentioned that on the COVID pediatric pathway. And you're right, Michelle, they COVID kids at home really want to hear from you if that's something you're considering.
Yeah, get on the line to them. And the other thing
can
about,
I just share my screen for 1 minute, Phoebe?
Yeah.
Would that be? So I keep talking, Michelle. I'll just.
Michelle, we did have another question come through just while I share Sandra's screen.
I just wanted to quickly say, if you're looking for the details for the COVID kids at home, can you see this now? That's got the drop-down box with all the COVID kids at home information. That's how to get in touch with them, and it's here on the Care of COVID Positive Pediatric Patients pathway. So,
and the wonderful thing about health pathways that you can do is, if you're not sure where something is, so you can press the expand all button, and you could search that page with Control F for like
Control
Paxlovid
F
or something.
Paxlovid.
And there you go.
And it comes up.
And that's the magic.
And you can see
trick.
every instance.
Honestly, 5 or 8 years of looking at health pathways before I found them. So
yes, that's actually, I should have mentioned that. Yeah, thank you. You can have the screen back now, Phoebe, sorry.
Thank you.
And there's a question from Brian. Have we started to see any reliable standardized instruments for screening for long COVID, given its multifactorial presentation, which is another excellent question, isn't it? Not that I know of. I think we're waiting for them to present themselves. It's almost like we don't want to go out there and find them all. I don't know. Have you seen anything come through, Sandra, on the pathway?
No. Well, we do have things like the Yorkshire Rehabilitation Scale. Is that, let me just, assessment and screening tools. Yeah, the COVID-19 Yorkshire Rehabilitation Screening Tool. When we first wrote the pathway, we wrote that this is the only validated tool and it can be self-administered. So, but I don't know if you've had much experience with that, Michelle.
I think there have been various NHS websites where you can go on and you can click through things and you can say, oh, you know, like you can with lots of things, you can do a bit of an assessment as to whether you have symptoms that are suggestive or not. But I don't think we're at the stage where we're going to be screening all of our patients for long COVID. We're expecting them to come forward with symptoms, I think.
Yeah.
The other thing I was going to say about Evershed is that until it's on PBS, it's supposed to be mostly driven by the specialists. isn't it? So because these sorts of patients should be, usually you would think, under a specialist. And so a lot of patients may already have had Evershed. I know some of mine have. But if the GP needs to drive it, then there is a prescription and dispense form, similar to what we had when we very first had antivirals. And that goes back via the hospital pharmacy, and then the patient has to pick the stuff up and bring it to you or your practice nurse to have the 2 injections. And then it's a 15-minute observation period afterwards. So it's a bit of a complex process at the moment. So if it's on PBS, then that will streamline that a bit, as we saw with antivirals, where the antiviral prescribing rocketed once it was on PBS.
Okay, well, we've hit our time. So I just wanted to thank Michelle, Sandra and Ellen and Peter, even though he's left us early. Thank you all for attending. And if you could please fill out the evaluation, I would consider a personal favour. Thank you for taking the time to attend tonight. I know that it does cut into family and downtime and dinner time, but really appreciate it. And thank you to all of our presenters.
Thanks, Phoebe.